So good morning, and thank you for the opportunity to speak, and thank you for welcoming a respiratory physician into the heart of immunology. What I'd like to talk about today is what's new in respiratory medicine, or if you like, how to look after lungs. No conflict of interest in relation to this presentation. And over the next 20 minutes or so, I've selected 6 topics. There are some new things around some of these topics. There are some old things too, but there are some old things that are important. And I thought what I'd like to do is to try and bring that together. And hopefully there's something for everybody in what I'm going to say over the next 20 minutes or so. Now, I don't know if you recognize these numbers. If you don't, you probably should. Because we're all breathing 12 times every minute. 60 minutes every hour, 24 hours every day. And that's 17,280 breaths each day. And with every one of those breaths, we're breathing in the air around us, and that air around us isn't clean. It contains things. And that's one of the main differences why the lungs are commonly affected in people living with primary immunodeficiency compared to, say, the kidney or other internal organs. So we could think about toxins, and I'd like to say a little bit more about something that's new there in just a moment. And we could also think about microbes, and I'd like to say something new in relation to microbes as well. Fundamentally, though, this is a balance between the things that we are breathing in, so toxins, microbes, but also against our host defenses. So we could think about physical host defenses. We could think about the integrity of the epithelial cell barrier. We can think about mucus, mucociliary clearance, and we can think about host defense proteins. We can also think about our acquired immune defenses, something that you know much more about than I do. But the balance between those two things, the toxins and the microorganisms that we're breathing in, our physical, innate, and our acquired immune defenses, is controlling the balance between health and disease. And clearly in people living with a primary immunodeficiency, the immunodeficient part of their PID may be responsible for lung disease, so for example, through an increased susceptibility to infection. But as we'll see a bit later on as well, perhaps some of the more difficult problems in relation to respiratory manifestations of primary immunodeficiency are when there's an overactivity of the immune system too. This isn't new. This vicious cycle has been described since the 1960s, and it was developed by Peter Cole and was really developed to describe what happens in bronchiectasis, but actually it's applicable more widely than that too. And it says that once damage has been initiated in the lung, there can be a vicious cycle of ongoing damage that can continue even when the initiating insult has been removed. So for example, if you have an epithelial injury, that might result in impaired mucociliary clearance. That in itself can lead to colonization with airway bacteria, and we'll talk a bit more about that in a moment. But those bacteria can themselves produce toxins which go on and cause further epithelial injury in a vicious cycle or spiral that leads to ongoing lung damage. Well, what's new? Well, there are a few things that are new in relation to toxins. You'll have seen recent news reports about air quality in Delhi, for example, a problem which doesn't just affect cities in India, it affects all of us wherever we live. I'm not going to talk any further about that, but what I am going to talk about is the issue of e-cigarettes, or vaping, or heated tobacco products. And as respiratory clinicians, this is something that many of our patients are asking us about more and more frequently. And it may well be that people with primary immunodeficiency are asking you about these products too. And it's important to say that there's quite a big difference of opinion, depending on where you work, about how we should or should not be advocating use of e-cigarettes and heated tobacco products. In some places, for example, the UK, people have said, well, we do not know the long-term harms associated with e-cigarettes, but the long-term harms of e-cigarettes are likely to be less than the long-term harms of cigarette smoking, and therefore, as a way of helping smokers to quit, e-cigarettes should be regulated and permitted in that context. Other jurisdictions, including many places around Europe and the US and other places where many of you will be working, have taken an opposite view. They've also said we don't know the long-term effects of vaping, of e-cigarettes, so everybody is agreed on that. But other places around the world, well, they said, because we don't know those long-term risks, we cannot advocate the supply and use of these devices at all. So, based on the absence of long-term scientific evidence, the advice around vaping is very different, is controversial. And into that controversy has stepped the recent publication of case series from the US, describing something that at the moment has been called vaping-associated lung injury. These are small case series of young and healthy people, many of whom have died, with a very severe, very rapid, very acute respiratory illness with a number of different histopathological patterns, which seem to be associated with the use of vaping products. A particular type of vaping product where cannabinoids and other oils were added to the vaping, but an illustration that we just do not know the safety of vaping. A controversial area, and we need to be thinking about how we advise people. I'm a member of the European Respiratory Society. That's our professional society as respiratory physicians and clinicians in Europe, and they've taken a very clear position statement about vaping. They have very clearly said, don't. This is an unacceptable thing to be advocating. The second thing I want to mention, which is new, is in relation to the way that we think about bacterial infection within the airways. The common story has been that the lower airway is sterile. And by sterile, I mean free from bacteria or other living microorganisms. And so people thought in health there were no bacteria residing within the lung. When you start to take that apart, you can see that there's the potential for a problem. Because what happens if we take a sputum sample or a bronchoalveolar lavage is it gets taken to the microbiology lab where it's handled and processed and put onto plates. And those plates, they contain selective media which are pre-designed to look for specific organisms, for organisms that we know to be associated with respiratory disease. And then different labs may report those organisms in different ways. They may report them selectively and suppress or not various different organisms. So when we were thinking about what sterile meant in the era of culture-based microbiology, what we actually meant was no growth of the potential pathogens that we were actually looking for and were capable of detecting. Now, it won't have escaped your notice that the respiratory tract is open at the mouth and at the nose. This is important. This is how we breathe. And so with every one of those 17,280 breaths that we're taking, microorganisms are accessing our lung. And so it took the development of new technology, 16S rRNA sequencing or microbiome technology, to create the realization that all of us have bacteria in our lungs all of the time. This paper just from 2010 was the first to describe the concept of a healthy human airway microbiome. On the inner ring of this figure, we have control subjects. In the middle, asthma, and on the outside, a lung disease called COPD, a smoking-related lung disease. And the different colors here represent different families of bacteria. And you can see the healthy patients and the patients with respiratory disease all have bacteria in their lungs, but there are different proportions of those bacteria. And look in particular at the red family. The red family, the proteobacteria, rather rare in health and rather more common in people living with chronic respiratory diseases. It's a very fast-moving field, summarized in this very nice European respiratory monograph published just this year. But to summarize a lot of basic science research, the lung microbiome is detectable in health and it's altered in disease. Different aspects of that microbiome affect clinical outcomes, exacerbations, hospitalizations, and they do correlate with variations in immunity, which is particularly important when we're thinking about implications of the microbiome in people living with respiratory manifestations of primary immunodeficiency. So there's a balance here between the microbial immigration and elimination in health. This is not a static picture, this is dynamic. But when there are problems within that growth environment because of structural damage in the lung, because of differences in mucus rheology, because of differences in immune system function, then local regional growth conditions become important and can result in outgrowth of species which are potentially more pathogenic. So a very dynamic situation evolving within the lungs. And it has some rather basic and profound clinical implications. Just because you have a sputum sample that doesn't grow any potential pathogens doesn't necessarily mean that there isn't a bacteria there causing a problem. And just because you have a positive sputum sample doesn't necessarily mean it's that organism that's causing the problem. And we also know that respiratory viruses are very important. Perhaps the way this is going in the future is attempts to restore eubiosis within the lung. We're already seeing that in gastroenterology. So, for example, fecal transplant to treat Clostridium difficile infection. We're not yet at the stage of sputum transplant to restore eubiosis within the lung, but that is the direction of travel of research to understand how we can modulate the respiratory microbiome to restore something that looks more like health. So some new aspects in relation to the balance there, and particularly in relation to toxins and microbes. I thought we'd look next, though, at a basic classification of respiratory disease, and we could divide that into acute and chronic manifestations, and we could think about the different structures within the lung that are affected, so the airway, parenchyma, and perhaps less commonly vasculature and respiratory pump. And if we do that in relation to people living with primary immunodeficiency, then clearly pneumonia and acute airway infections are the commonest, including exacerbations of underlying disease like bronchiectasis. But people with PID can also get PID-specific problems, and we're going to be talking a bit more about those later on, and in particular this autoinflammatory, autoimmune manifestation that some people with CVID are living with called GLILD, or granulomatous lymphocytic interstitial lung disease. Patients with PID can also, of course, have the other common respiratory diseases which most of us as respiratory clinicians spend most of our time looking after. Asthma, COPD, pulmonary embolus, sleep-disordered breathing, and we're going to be hearing more about NTM, non-tuberculous mycobacteria, a little bit more in this session as well. The clinical assessment of respiratory disease hasn't really changed, but I would encourage you to ask particularly about exposures. So exposures in relation to smoking and vaping as well, and to exposures like cannabis, which people may not be volunteering unless you're asking them directly. Also occupational exposures and domestic exposures. The exposure history is important to us in respiratory medicine. And clearly investigations are our backbone in understanding and monitoring lung health, and let's talk a bit more about those too. And I do want to talk about some developments in investigations, but I also want to emphasize the importance of some older, simpler investigations. I hope you haven't forgotten what this is. This is called a chest X-ray. It's simple, it's cheap, and it's not associated with very much radiation exposure. And here we have sequential X-rays of a patient with CVID and this autoinflammatory condition called GLILD, showing a response to immunosuppression. Yes, we get much more information by repeating a CT scan, but that CT would be associated with additional radiation, additional expense, additional inconvenience. We can get information from simple investigations like chest X-rays, and we should remember that. Most of our information perhaps comes from physiological testing in respiratory medicine. The reference is on the bottom of the slide there. If you haven't seen this before, it's a helpful scheme of how to interpret simple lung function tests because it guides us in this great division in respiratory medicine between conditions associated with airflow obstruction like asthma and COPD and bronchiectasis, and conditions associated with restriction, typically interstitial lung disease and problems with the chest wall. So here by using simple tests including spirometry, total lung capacity, and gas transfer, we can come down to a subset of diagnoses. And I really do want to emphasize the value of these simple physiological tests in monitoring people with lung disease. A moment ago, I showed you the X-ray of somebody with GLILD, and this is his lung function test in response to immunosuppression too. And you can see a profound improvement in his gas transfer between April and September of this year. Notice also that his spirometry was normal in April, his FEV1 98% predicted and VC 97, but in response to treatment, his test became supranormal. So a normal result on a lung function test doesn't necessarily mean it's normal for them. Some people have above average lung function, and so we sometimes see unexpected changes, for example, in this instance here. One of the problems with spirometry is that it's effort dependent. If a person isn't coached to give sufficient expiratory effort, the result is a low reading that can falsely indicate disease. And so the search has been on for effort-independent pulmonary function testing, and that search has resulted in this technique called force oscillation. You may or may not be familiar with that. It's relatively new. This applies a sinusoidal pressure wave at the mouth and is accompanied during tidal breathing. It gives measurements which are analogous to some measurements on spirometry, but without the need for a force maneuver. The respiratory medicine community is getting to grips with forced oscillation, and I think it's going to be something that you're going to be hearing more and more about over the coming years. The other thing to mention in relation to physiological tests is that most of our tests are done static. They're done sitting or standing. And actually what people with respiratory disease and people with PID and respiratory manifestations complain of, mostly, is problems when they're doing something, not when they're sitting or when they're standing. And so ultimately, if we really want to understand what's happening when somebody's exerting themselves, we need to do an exercise test, so cardiopulmonary exercise testing. It's a complex test, and its use needs to be done carefully, but it is the ultimate arbiter of whether somebody is limited by their respiratory problems, by their cardiac problems, by being unfit, or whether they're exercising not enough. So we do need to remember that exercise physiological testing can add a lot of value to the static tests that we do too. Our standard state-of-the-art in relation to respiratory imaging, which provides complementary evidence to the physiological test, because now we're seeing anatomy, now we're seeing structure, remains high-resolution CT scanning. This shows bronchiectasis, and we'll have a look at it again in a minute. But this is moving forwards too, so we now have functional CT through the use of FDG PET, primarily a tool, of course, to look at malignancy, but I show you here as an example the FDG PET scan of somebody with GLILD again, showing that there is increased uptake within the lung parenchyma, suggesting that there's metabolic activity here which may be susceptible to interventions which can suppress that activity. On the right of the screen, we have a CT scan of somebody with GLILD, and on the left, we have their contemporaneous MR scan. You can see that the MR scan is never going to be able to replace that CT in terms of the resolution within the lung. The physics of MR scanning in relation to air tissue boundaries means that the resolution of MR is never going to be that good. But the MR may give us complementary information. And of course, it's not associated with radiation exposure either. So in terms of monitoring disease, there may be great value in using MR in association with judicious use of CT. Different MR signals may give us information about edema within a nodule or cellularity within a nodule. And to take things even further, we now have available as a research tool primarily hyperpolarized noble gas MR, so hyperpolarized helium or xenon, which enables us to make regional assessments both of perfusion and ventilation and gas uptake. This is expensive. This is not available in many situations at the moment, certainly not available clinically in very many places, but it is giving us new insights into the pathology of conditions within the lung, and contrast-enhanced hyperpolarized MR, something which I think we're also going to be seeing much more of as respiratory medicine moves forward. A word about therapy in respiratory disease, and in particular, I want to emphasize the importance of non-pharmacological therapy. This is a photograph of a pulmonary rehabilitation class. And models of pulmonary rehab vary, but this is an outpatient ambulatory care, education, and activity class for people with chronic respiratory disease. People typically come twice a week for about 6 weeks for 2 hours each visit. They get an hour of exercise, personalized, graded exercise from a physiotherapist, and an hour of education. And in terms of evidence, randomized control trials, meta-analysis of randomized control trials, the evidence to support the use of pulmonary rehabilitation across a range of respiratory diseases is irrefutable. Getting someone onto a pulmonary rehab class is one of the most important things that I can do as a respiratory clinician looking after somebody with chronic respiratory disease. Of course, we're often more interested in the drugs, and I'm going to end by talking about bronchiectasis in a minute, but just in passing, just from the New England Journal of Medicine this week, new data about one of the 2 drugs, pirfenidone and nintedanib, that are now licensed for use in interstitial lung disease. Originally licensed for use in a particular type of interstitial lung disease called IPF, particularly when it's associated with a particular histological pattern called UIP. But more recent data, a few weeks ago now, looking at scleroderma-associated lung disease, and this from this week, looking at people who don't have those typical patterns, suggesting that nintedanib may actually have some benefit in people with undifferentiated ILD. And I would strongly argue that there is the emerging need for a clinical trial in people with ILD associated with primary immunodeficiency. Endpoints here are in relation to vital capacity rather than clinical endpoints, but this is transformational in the management of interstitial lung disease. To end then, bronchiectasis, and I show you the CT scan again. Bronchiectasis, as a reminder, is a condition of dilated airway. So on the left, the internal diameter of the airway, dA, needs to be greater than the diameter of the blood vessel, dV. It's not about thickened airway walls, although that can tell us interesting things too. To have bronchiectasis, you have to have dilated airways. There's a lot going on in bronchiectasis within the field of respiratory medicine at the moment for all sorts of reasons. We now have much better ways of prognostication in people with bronchiectasis, including these 2 validated scoring systems published a few years ago now, FAST on the right, and the Bronchiectasis Severity Index, slightly more complicated, but probably slightly better on the left. And there's a handy web tool calculator, the link's there, if you want to use that to think about prognosis in people with bronchiectasis. There's also new guidelines around the management of bronchiectasis from the European Respiratory Society on the right of the screen there. Fundamentally, that hasn't changed in terms of the basics. So the basics are treat the cause, which of course in people with primary antibody deficiency means adequate, comprehensive antibody replacement. Next is physiotherapy, and I can't emphasize enough the importance of physiotherapy in people living with bronchiectasis before we consider other things in terms of infections and new drugs, which I'll come on to in a moment. There's now strong evidence that macrolide antibiotics are the treatment of choice to reduce the risk of acute infections in people living with bronchiectasis based on 3 randomized control trials, BAT and BLESS and EMBRACE. They used 2 different macrolides, they used different doses, they had different recruitment criteria, but they all had the same outcome in terms of a reduction in exacerbation frequency. I should point out that across those 3 trials, only 1 person was enrolled who had a primary antibody deficiency, so we don't know for sure that this is true in people living with PID2, but we have no reason to assume that it's not. Our concern with macrolides is the development of non-tuberculous mycobacterial resistance, which I suspect we're going to be hearing a lot more about in just a second. And then just to mention in passing emerging treatments for bronchiectasis. So we are seeing inhaled antibiotics, increased use of hyperosmolar agents, so for example, hypertonic saline, cystic fibrosis transmembrane regulator interventions, which are transforming the outcomes for people with cystic fibrosis, are also being examined in non-CF bronchiectasis. And we're seeing trials of novel anti-inflammatories coming through, including CXCR2 antagonists and anti-IL-5. So it's a very fast-moving field. From having had no licensed interventions at all in bronchiectasis, there's now a considerable amount of interest, and in part that's being driven by this EU-wide initiative called EMBARC. It's an incredible resource for clinicians and actually for people living with respiratory diseases too, and if you're not familiar with it, then the link is on the screen there. Perhaps one of the greatest challenges for us, though, as respiratory clinicians and immunologists working together, is the reduction and the treatment of acute infections. And this is some data from our own group that we published just a year ago now, looking at which symptoms drive people to use their rescue antibiotics. And unsurprisingly, it's breathlessness and phlegm. But even in a group of people who've been coached and educated about the importance of breakthrough infections, so a group of people living with primary antibody deficiency, there was still a median of 5 days between symptom onset and them taking their course. We know that delayed onset of antibiotics is associated with longer recovery and more likelihood of long-term lung damage. So supporting people in knowing when to take their breakthrough infections is one of the most important things that we can do as a multi-professional team. And as immunology clinicians, I know that you're used to working in multi-professional teams of immunologists, nurse specialists, psychologists, and many, many other people too. But let's broaden that out and let's think about who's relevant to pulmonology, to respiratory medicine, our physios, our pharmacists, our physiologists, our radiologists, and yes, even your local pulmonologists, because it turns out that most of us are quite nice. I strongly believe that through multi-professional working, we can improve the outcome for people living with primary immunodeficiency, and I would encourage us all to do that, and I would say that our patients deserve nothing less. I'm really grateful to IPOPI for the opportunity to speak to you today. It's a lovely invitation to have. I'm happy to answer any questions if we have time, or if not at the break. Thank you very much for your attention.